Hi everyone, I want to talk about high output heart failure. High output heart failure is called its name because there is a very high cardiac output and decreased systemic vascular resistance. Yet this individual is having other features of heart failure that can lead to decompensation or aggravation of the existing heart failure. There's increased metabolic demand with increased oxygen consumption, and there may be borderline preserved ejection fraction. There's also the possibility of increased filling pressures and decreased systemic blood pressure. It can't cause heart failure on itself alone. Therefore, we must look for the real cause or causes if we are picking symptoms. In other words, if a patient is having high output heart failure that is symptomatic, then we must look for the cause or causes. On its own, should not be a problem, but if there is a pre-existing cardiac problem in any way, then, or there is heart failure that is not bad before, then it can lead to decompensation, in that situation, or aggravate or worsen the existing heart failure. Okay, the etiology is very important because that is what we are going to treat here. Okay, like I've just said earlier, high output heart failure on its own is not a problem, but the underlying problem is what we are going after. Because with that, it can then lead to decompensation or worsen existing heart failure that has not been symptomatic before now. So, talking about hyperthyroidism as a possible cause, that will lead to peripheral vascular effects. And of course, metabolic activities will rise, and the effect on the heart is part of what we're dealing with now, high output heart failure. Arteriovenous fistula, left to right stenotitis from high pressure to low pressure, Paget's disease, renal disease with dialysis, hepatic disease with liver cirrhosis. Beriberi is not common in advanced countries. It's still found in some other parts of the world, but it could be found in advanced countries in alcoholics or anorexia nervosa. And the individual will come down with possible Quincke encephalopathy, or because of thiamine deficiency. And the treatment here is just thiamine administration. And we're out of the heart problem. Isn't that great? Yeah, it is, of course. Anemia. When there's anemia, maybe hypovolemic, going down from massive hemorrhage or whatever, there will be tachycardia, tachypnea, and so on and so forth. Dyspnea, everything like that. So the body is sending messages to the heart, pump more, and will lead to hyperdynamic states. Like pregnancy. In pregnancy, there will be increased metabolic demand. We know that. The blood volume will increase because there is associated placental blood flow also with decreased vascular resistance. What is going to happen to the heart rate in all these situations? Of course, it's going to rise. And the resting cardiac output will increase. The heart failure here will only occur if there's a pre-existing cardiac disorder. Another possibility is acromegaly, also chronic pulmonary disease leading to pulmonary and renal failure, sepsis, carcinoid syndrome, traumatic atrioventricular fistula, that is surgical connection, obesity, dialysis, I've just alluded to that, we're talking about renal failure, and myeloproliferative disorders. Exercise. We all know that. I don't need to waste your time going over that. Fever, emotional stress, hot weather. Oh, repeating pregnancy? Okay, maybe because I'm feeling for pregnant women because they have extra burden to cope with. Clinical features. The clinical features, it seems like those already presented in my first video. But something is significant here. In my first video, I made mention of possibility of extremities becoming cold and clammy. But in high output heart failure, you're not going to get that. Instead, you're going to get warm and well perfused extremities. The heart rate will rise, the stroke volume will be up, and there'll be bonding pulse. It might collapse very rapidly, and you're going to find what is called wide pulse pressure, that is the difference between systolic and diastolic. Capillary pulsations is likely going to be possible or visible, and that is called Quincke sign. Pistol shot signs are the femoral arteries, that is bruit signs, is likely going to be present. When you auscultate the carotids on the neck bilaterally, you're likely going to get carotid bruit, venous hum, and hyperdynamic precordium. Be suspicious of high output heart failure in patients with features of heart failure, but they are having well perfused and warm extremities. Also having cardiac output greater than 8 liters per minute, but with signs and symptoms of heart failure. Because why that? Somebody is having signs and symptoms of heart failure, and when you use your catheter to determine the output, you are getting 8 liters per minute. Very high output, yet with signs and symptoms of heart failure. Then you make your diagnosis. High output heart failure. The heart is failing, but the output is still very high. Not exactly the same with heart failure with preserved ejection fraction. It's not exactly the same. Do all the lab and radiological investigations. I have a separate video on that. And look for the cause or causes, please, because that's what we're going to treat. The treatment is generally the same the way we're going to treat anyone with heart failure with reduced ejection fraction. But we have to look for and treat the underlying pathology. If not, we're not going to get out of it. So with that, I come to the end of this very presentation, and my next presentation will be heart failure treatment generally. Thanks for listening, and kindly subscribe, and you'll be getting these publications immediately they are released. Thank you. I appreciate that.